Hi, this is RAQD Clinics. I'm Jack Cush with Room Now. Today's case is RA in deep remission. You see these patients. I see these patients. This patient is 64 years old. I've been caring for this patient for, oh my goodness, it looks like 15 years. And she's doing great. She was diagnosed going way back based on having chronic symmetric polyarthritis of the wrists, MCPs, ankles. She was strongly rheumatoid factor positive, but CCP negative. At the onset, she had carpal tunnel syndrome, which brought her to her family doctor, then to the rheumatologist, and then hence the diagnosis with me. Over the years, she has been treated with, I think initially with, where do I have that down? I don't have that down. I'm pretty sure she was on sulfasalazine in the beginning when I got her, and then I put her on methotrexate, and then later, she, after 2003 or 4, she went on adalimumab. Today, she's taking celecoxib once or twice a day as needed, and she's on the adalimumab every 2 weeks. Like the last 6, 7, 29 visits, she has no complaints, says she's doing very good, denies any morning stiffness, has no sleep problems. On exam, has a TJC today of 2 joints, the left wrist and a I'm not sure something else. Actually, I guess 1 joint, and then no swollen joints. And her CDI score is 2. But if I look at all of her CDI scores over the last 3 years, half of them are zeros, a quarter of them are 1, and a quarter of them are 1, 2, or 3. So this patient, by CDI, is in deep remission. She always has normal labs. Her main health problem is she's 200 pounds and overweight for her size. She has, a few little other problems like diverticulosis in the past. She takes thyroid medicine. She does have type 2 diabetes and hyperlipidemia, but those are well controlled with medicines. So now the question is, she's in deep remission. Do I offer her the opportunity to wean off of her adalimumab? She's not on any of the DMARD, just the adalimumab. You may have heard me say during one of the Tuesday night rheumatology sessions this week that I never encourage de-escalation or dose reduction or stopping. Never. Now, never say never, right? And if there was ever a patient whom I'll entertain, I'm very much against it because the data is very clear. The vast majority of people who meet remission criteria for 12 months do very well, but, turns out that 30 to 50% will flare, and that most of them will recapture if you put them back on therapy. So my point is, why even chance it? People who, in these studies where they follow them and they're in deep remission and they follow them over another year, they show that 15 to 30% of those people who have no change in their medicine still get flares. So anyway, I would consider offering dose reduction, in this case, taking adalimumab once a month, which, it does have a long half-life. That probably is sub-therapeutic, but maybe effective. Or after doing that for 2 or 3 months or 4 months, stopping the drug. Why would I do that, given what I just said? 1, my rules would be deep remission. A -28 score of like 2.2 or less, or a CDI score of 0 or 1 for a year. But then the most important part is no other good reason for them to have pain. They've got secondary fibromyalgia, don't do it. If they've got secondary OA, don't do it. If they've got depression or other reasons why they may get pain intermittently for reasons beyond your control, don't wean their RA therapy because you and the patient will not know whether the flare that you will be dealing with is from that other problem, their diabetic chiroarthropathy, or the fact that you withdrew biologic and or DMARD therapy in someone who still has clinically active RA. So it turns out in this patient, I did offer weaning or stopping the adalimumab, and she's been on the medicine for so long, like 14, 15 years, something like that. She doesn't want to change anything. She's very happy with the status she's in and taking her shot every 2 months and seeing me every 6 months. So they're happy, I'm happy, we move on. The thing I heard this week from Dr. John Goldman in a discussion on this topic is a great relationship with the patient allows you to have these conversations, allows the patient to sometimes wean therapy. But that means that they're going to tell you about their experience and that you and the patient together can come to a decision about future therapy, especially if they happen to get worse or have a flare. Maybe the flare is something you just treat, sporadically with, analgesics and rest, hopefully not steroids. Or maybe the flare is such that you have to go back on the oral DMARD or the injectable biologic. Again, this is my asterisk as to when I might allow weaning of effective therapy in RA. Hope you enjoyed this month of RA QD clinics. I have.